Kristen Atchison here, and we're still talking about psychological disorders. Today we're talking about mood disorders and eating disorders. So mood disorders are different from the occasional mood swing that we have, where we might have a good day and then we might have a not so great day. But a mood disorder really involves a significant and persistent disruption in mood or emotions. And this not only causes differences in mood, but it causes impaired cognitive, behavioral, and physical functioning. So again, this has to be that disruption, this has to be maladaptive, this has to cause disruption in the individual's life. And so we see cycles of mood disorders. They're going to be different depending on the kind of mood disorder they are. The middle of this graph on the y-axis is 0. So this would be kind of baseline, emotional baseline. This would be kind of that level of homeostasis that we're kind of comfortable in. And we see someone that has bipolar over a 12-week period can have multiple episodes with mania and have episodes of normality, of this kind of baseline feel, and then also have episodes of depression, where someone who has major depressive disorder is going to primarily be at baseline or below baseline in terms of emotional feeling in terms of a depressed mood versus a manic mood. And so again, we're going to see these kind of differences, and these are persistent disruptions. This isn't you had a bad day. This isn't, it's just, something sad happened and so you're sad. This is, again, persistent disruptions. And because of this disruption, they're causing problems in cognitive, behavioral, and physical functioning. And so just like we've talked about in the other disorders and we talked about in our overview of psychological disorders, we've got different factors that play into mood disorders, one of which is the biological aspects and explanations. This is going to include things like the evolutionary history, genetics, the brain and the body, so those physical characteristics. It's also going to include things like neurotransmitter function when we're talking about brain function. We're also going to talk about differences in brain structure and brain activity as well. And then again, the psychological and sociocultural factors can play in as well. And this includes things like negative thoughts and negative mood, how people explain situations, their explanatory style, and then this kind of vicious cycle of these kind of ruminating on things and using that explanations to create negative thoughts and mood, and then kind of back and forth between those in this cycle. Genetics, again, plays a huge role in mood disorders. We see that there are areas of genes that are revealed to be have this depression piece to it. We see also huge heritability studies in twin and adoption studies, huge rates of this. And we see it's even more so for bipolar disorder, which is roughly above 80% in terms of heritability estimates, than we do for major depressive disorder. But major depressive disorder is pushing 40% too. So we're seeing really huge levels of heritability, and that genetics is playing a really large role in this. We will also see that we're going to have differences in brain activity. So we'll see brain activity is diminished in depression and increased in mania, in times of mania. If you look here at this image, this is one individual who had rapid cycling bipolar disorder. So they would rapidly cycle between kind of a depressed mood and a manic mood. And so we see May 17th, this person has experienced depression. May 18th, we're seeing this mania, this increased activity. And then by May 27th, we're back down to a depressed state again. And so we're seeing these differences in brain activity. We're also seeing differences in brain structure. So we see fewer axons in people with bipolar disorder, which again may be a result of some of these genetic components and why we see such a high heritability rate for bipolar. We also see there's differences in brain cell communication, so neurotransmitters. We see more neuroepinephrine in mania, and we see less in depression. We also know serotonin is related to mood disorders, and we'll see things when we get to our therapy chapter, like medications that are selective serotonin reuptake inhibitors are predominantly prescribed for major depressive disorder and some anxiety disorders. So we'll see that there's lots of different neurotransmitters at play here. So let's talk about major depressive disorder first. The diagnosis and symptoms of this include significant depressive episodes that last for at least 2 weeks. And again, we need to have this impairment in functioning for this to be major depressive disorder. We also see other symptoms can include things like fatigue, a sense of worthlessness, reduced interest in things. We'll see also differences in appetite and sleep disturbances. We can see cognitive function issues, such as short-term memory problems, things like that. Looking again from that biopsychosocial approach, we see that all of these kinds of things are involved in major depressive disorder. So biological function factors include things like, again, that genetic predisposition. We showed, again, that slide where it had it about 35 up to 40%. We also see differences in the prefrontal cortex. So we see an underactive prefrontal cortex in depression. And we also see, again, that regulation of neurotransmitters that we've already talked about a little bit. And again, that we'll talk about more when we get to our therapy chapter. In terms of psychological factors, things like learned helplessness is a problem. We also see ruminating on negative, self-defeating thoughts. Ruminating is not when you think about something once, but that you have this kind of overarching hyper-focus and that thought keeps coming back and back. And we also see that a pessimistic attribution, so those pessimistic outlooks, can be a factor as well. And then social cultural factors, poverty, obviously, other kinds of situations that would normally induce stress or sadness. It can be social cultural factors. And then once again, we're going to see differences in terms of gender, in terms of diagnoses. For the DSM to be, the DSM criterion to diagnose with major depressive disorder, you have to have one or both of these first two, a depressed mood, most of the day, and or a marked diminished interest in pleasure and activities. And then you have to have at least 3 more of the rest of these. So significant increase or decrease in appetite or weight, insomnia, sleeping too much or disturbed sleeping, lethargy, physical agitation, fatigue or loss of energy nearly every day, worthlessness, excessive and inappropriate guilt, daily problems in thinking, concentrating, or making decisions, and reoccurring thoughts of death and suicide. And we'll come back and talk about death and suicide more at the end of our psychological conversation in class. The rates of major depressive disorder with adults, we see that about 7% of the U.S. population indicates in the past year, in 2017, had major depressive disorder. Again, we're going to see that's disproportionate between males and females. Again, we're going to see more women with these diagnoses than males. And that's, again, one of those sociocultural factors. We're also going to see differences in age as in this as well. So we're going to see younger adults are more likely to have problems with major depressive disorders than older adults are. And we can see differences in ethnicity as well. So we see people... We see a higher incidence in people of European descent. We see an increased incidence when someone has more than one racial or ethnic identifier. And we'll see differences in different cultures again. And these are, again, those social cultural factors that play in. We also see different rates among adolescents as compared to adults. So we see a higher rate in general for adolescents than we do for adults for depression. And here we see it's even more, this gender difference is even larger. We see up to 20% of adolescents in 2007, female adolescents in 2017 had major depressive disorder. And again, we're seeing differences in this in adolescence, with the incidence increasing into the high school years. And then we're going to see differences culturally as well, where we see higher incidences just across the board, but we are seeing some ethnic differences as well. In terms of bipolar disorder is characterized by these extreme mood swings that include mania. And this, there can be frequency and separation of the episodes. They can be separated by long periods of time, kind of 6 months to a year, but they can also have kind of more rapid cycling, which is what you saw in those brain imaging images that I showed. And the kind of cause behind that, again, we see a really, really strong genetic component. Here again, you can see that identical twins are going to be genetic clones. And we see that the risk of that is about 70% if an identical twin has it, where it goes down to about 10% in fraternal twins, which are going to be the same as any other sibling pair. And then we're, down very, very low for the general population. So we have a really, really strong genetic component for bipolar disorder. But we also see swings in activity in the cerebral cortex. And again, neurotransmitters are going to be at play here as well. In bipolar disorder, it's again kind of identified by these really contrasting symptoms. So we have the depressed mood, this stuck down feeling with exaggerated pessimism, social withdrawal, lack of felt pleasure, inactivity, lack of initiative, difficulty focusing, fatigue, and excessive desire to sleep. But then this is really contrasted with these manic episodes where we have euphoria, giddy, easily irritated. And in these, we see exaggerated optimism. We see hypersociality and sexuality. We see a kind of delight in everything, impulsivity or overactivity, racing thoughts, the mind won't settle down, and little desire for sleep. So you can see that these are kind of polar opposites. And so this is where this disorder is getting its name, is we're really seeing huge differences in mood. And again, these can be over 6 months to a year, but they could also be in rapid, more smaller cycling as well. So that really ends our mood disorder discussion. We're going to move on to eating disorders. So for all eating disorders, they have a strong genetic component and problems with neurotransmitter regulation. I think previously our culture really, currently our culture really thinks about eating disorders as something that's behavioral, and it's just you need to eat more or you need to eat less. But again, these have really strong biological factors. This is not just a sociocultural issue. These have really strong genetic components, and we see problems with neurotransmitter regulation with these. So in anorexia nervosa, we see a relentless pursuit of fitness, and this is done through starvation primarily. Sometimes exercise has been added in, but it's primarily through starvation. And this is a significantly low body weight and a refusal to maintain a healthy weight. We see an intense fear of gaining weight that does not decrease as weight is lost. This person is scared of gaining weight even as they're losing weight. And so we see this, again, this really disordered, this kind of lack of awareness, this lack of rationality between kind of reality and what's happening and what the thoughts. We also see hugely distorted body images. So these people will report that they look very different than they do. And so again, we have this distortion in their body image. And we see huge long-term physical consequences for this because this is done through starvation. And so those physical consequences that we're going to see are going to be similar to that of starvation. So we're going to see consequences to bones, hair loss, blood pressure. We can even have damage to the heart and the thyroid be possible because of this starvation. And another thing that's really important to note is that anorexia actually has the highest mortality rate of any psychological disorder. And so because this is not only are these individuals at risk for suicide, but they're also at risk for these physical consequences and these illnesses due to the starvation. And so they're kind of getting double hit with both the psychological piece of it, but also the physiological illness that's caused by that starvation. So we see really the highest mortality rate in any psychological disorder in anorexia. The next one we're going to talk about is bulimia. And what we see in bulimia is this constant binge and purge eating pattern. And these individuals typically have a normal weight. And so it's a lot harder to detect when somebody is bulimic. We do also see there's a lot of shame associated with this binge and purge eating pattern. So they're not always doing that in the situations that anyone else is aware of it, because there is an intense shame attached to it. We also see a preoccupation with food here. We see, again, this irrational fear of becoming overweight. And we also see really difficulties controlling emotion. And because of this binge and purging situation, there's going to be a lot of this throwing up, this purging can have a lot of physical consequences as well, including damage to the throat, the kidneys, dehydration, gastrointestinal disorders, and dental problems because of all the stomach acids that are coming up through the gastrointestinal system and over the teeth that aren't meant to. The teeth aren't meant to have contact or constant or often contact with those. We also see people that are bulimic tend to have really, really high standards, but also really, really low self-confidence. And so these kind of differences between them can cause a lot of psychological dysfunction, a lot of psychological disorder. We also see that people with bulimia, we really see a correlation with physical and sexual abuse in childhood. And so while we're not talking about causation here, we do see this correlation where we see a positive correlation where people who are physically and sexual abused are at a higher risk for bulimia. So again, we do see this correlation, but again, correlation does not imply causation. And finally, we have binge eating disorder, which is a recurrent episodes of excessive or out of control eating. And what's important to note here is that this is actually the most common of all of the eating disorders, and about 2 to 5% of Americans actually have binge eating disorder. These individuals are using food to regulate emotions. Sometimes people talk about this as kind of food addictions. And we see that these individuals tend to have biological differences, including things like an overactive endocrine system. Our endocrine system is going to be important in healthy eating behaviors. And so when we have this overactive endocrine system, it can have negative consequences on healthy eating. This ends our conversation on mood and eating disorders. Thanks so much.